Alright, we just covered the intravenous agents used for the induction and maintenance of general anesthesia. Now it's time to take a few deep breaths and count backwards from 100, because this sketch is all about inhaled anesthetics. The development of non-pungent, non-irritant volatile anesthetics such as sevoflurane has made inhalational induction of anesthesia via a face mask more pleasant and a viable alternative to IV induction. This can be especially useful for children who might not sit still while you clumsily try to get that IV in. You know, nothing reminds me of inhaled anesthetic agents more than my own 10th birthday party. Good times. Balloon animals, bounce houses, friends. I had so many friends. So many. I'm so alone. So, since we're talking gaseous agents here, we're going to be making some balloon animals today as we... Oh, no. No. Is that a clown? I specifically told them I cannot do clowns. It's okay. I'm calm. I'll just put my hand up to the... Yeah, that's better. Okay, where was I? Gaseous anesthetics. The potent volatile inhaled agents, or N2O gas, may be administered as supplemental agents to deepen anesthesia after initial induction with IV anesthetic agents. Though the precise mechanisms responsible for the ability of these inhaled agents to induce anesthesia are not known. Maybe some GABA-E or glycine-E stuff. Antagonize NMDA much? Who knows? But before we get into the special class of volatile anesthetics, let's briefly discuss nitrous oxide, commonly known as laughing gas. Which is why Braden over here is getting laughed at as he inhales that nitrous oxide balloon. You might have had some of your own experience with this inhaled induction agent when your dentist put you under anesthesia before removing your wisdom teeth. But if your extraction went anything like mine did, most of the laughing took place after the procedure as you stumbled to the car in a stupor, demanding that everyone calls you Count Chocula and that the blueberry apocalypse is afoot. While nitrous oxide has a low boiling point and is gaseous at room temperature, the volatile anesthetics have high boiling points and are liquid at room temperature. That's why this volatile gas container is tipping over into the liquid inside this kiddie pool. It's still administered by inhalation though, so that kid better back off. See that balloon flower he's clutching onto as he slowly succumbs to the volatile fumes? Let it remind you that the volatile anesthetics are fluorinated and end with the suffix fluorane or just ane, like enflurane, isoflurane, and halothane. The distinction between volatile anesthetics and nitrous oxide is an important one, and later on in the sketch we'll cover a few important side effects that are only associated with the volatile agents. Inhaled anesthetics, volatile as well as gaseous, are taken up through gas exchange in the alveoli of the lungs. On the exam, you'll need to know a few important properties of these agents that determine their pharmacokinetics. Their uptake from alveoli into the circulation, as well as their distribution and partitioning into body tissues, determines the onset and duration of CNS effects. First, let's talk about solubility. Specifically, solubility of the inhaled anesthetic gas into the blood. It will be represented here by kids running the ball pit race. The balls are red to evoke an image of red blood cells in the circulation. The smaller kid in the red starting lane is able to freely move through the ball pit, thus he represents a highly soluble anesthetic, highly soluble in the blood, that is. The more, let's face it, hefty kid in the blue starting lane is kind of struggling there. He represents a less soluble anesthetic, obviously. Why is this distinction important? Well, the solubility of the gas in the blood determines the speed at which the blood becomes saturated with anesthetic. Just take a look. The less soluble kid in the blue lane immediately gives up and passes out from exhaustion. He's immediately saturated. I mean, just look at him. That didn't take long. If an agent has poor solubility, the amount of gas needed to saturate the blood is small and brain saturation occurs very quickly. In other words, the less soluble your anesthetic, the faster the blood gets saturated, the faster your brain takes up the anesthetic, and the more rapid the induction of anesthesia. Not only that, his equally hefty friend has noticed and immediately pulls him to safety. What this means is less soluble anesthetics have faster onset and a faster recovery. In contrast, take a look at the highly soluble kid in the red lane easily moving through the ball pit. He only passes out from exhaustion after he gets all the way to the finish line. In other words, his saturation is delayed. Highly soluble anesthetics are easily absorbed into the blood, and thus larger amounts must be absorbed before the blood becomes saturated. This means saturation of the CNS is delayed. Not only that, this highly soluble winner holds our recurring long tapering flag that represents greatly extended serum half-life. What this means is more soluble anesthetics have slower onset and a slower recovery. And I wish I could just leave it at that, but as you know, medical textbooks need 5 names for the same thing because science. So on the exam, you may see the term blood gas partition coefficient. Just replace that term with the word solubility and you're good to go. We've included this partition in between the lanes with arrows pointing to the finish line to make it easier for you. Higher partition coefficient means higher solubility and more delayed onset. Lower partition means lower solubility and more rapid onset. On an exam, they may also present a graph comparing the arterial tension curves of 2 anesthetics, but don't let it fool you. Again, all you're looking at is solubility affecting time to saturation. Nitrous oxide, for example, could be represented by that blue line. It's poorly soluble, just like the poor kid in the blue starting line, and it has low blood gas partition coefficient. Low solubility means the partial pressure of N2O in the blood rises rapidly and plateaus, indicating that the blood quickly becomes saturated with anesthetic. In contrast, the red line could represent an agent like halothane. It's highly soluble, just like the kid at the red starting line, so it has a high partition coefficient. Its partial pressure in the blood rises more slowly, and as you can see, the red curve for halothane eventually levels out at the same partial pressure as N2O, but it took significantly longer, and by this point, far more halothane has dissolved in the blood. Alright, besides gas solubility, the other property of inhaled anesthetics you need to know is the minimal alveolar concentration, or MAC. MAC refers to the percentage of anesthetic in the inspired gas mixture that renders 50% of patients unresponsive. And in this sketch, MAC is represented by that childhood staple, mac and cheese.
Minimal alveolar concentration. It's the cheesiest.
See how one kid has engorged himself to the point of unconsciousness while his friend feigns concern and pokes him with a fork? Because MAC corresponds to the dose that causes 50% of patients to become unresponsive to painful stimuli, we've made one kid awake and one kid asleep and unresponsive. MAC corresponds to the ED50 on the dose effect curve. In other words, find where effect or response is 50% and draw a line through your graph to find the concentration at which this happens. Another word to look out for is potency. The potency of an inhaled anesthetic is determined by the minimal concentration that reaches the brain that's necessary to achieve an adequate level of anesthesia. Potency is inversely proportional to MAC. The lower the MAC, the more potent the anesthetic. And to show that they are inversely proportional and that potency is merely 1 over MAC, we've inverted this mac and cheese bowl onto this kid's head.
I guess he just couldn't handle that more potent and cheesy flavor.
Apart from their desirable actions on the CNS, inhalation anesthetics affect almost all organ systems of the body. Cardiovascular effects include myocardial depression, leading to a decrease in cardiac output and an increase in arterial and ventricular pressures. Hypotension is associated with fluorinated anesthetics because of this decrease in cardiac output. Another thing to remember, all inhalational anesthetics except nitrous oxide are respiratory depressants. So we've also added in some deflating lung balloons. They decrease the tidal volume and minute ventilation and cause hypercapnia. Not only that, they suppress mucociliary clearance, which may contribute to postoperative atelectasis. In the brain, fluorinated anesthetics decrease vascular resistance and actually lead to an increase in cerebral blood flow. Just think of this clown's wacky but surprisingly cerebral-looking hair. This increase in cerebral blood flow is an undesirable effect as it results in increased ICP. The volatile anesthetic halothane can cause severe liver damage, including massive hepatic necrosis. For this reason, it is rarely used in the United States, although it's commonly used worldwide. Just remember the H in halothane stands for hepatotoxicity. Or just remember this hepatic piñata, suffering from some delicious necrosis as we speak. Clinically, halothane-associated hepatitis presents in 2 days to 4 weeks after the exposure to anesthesia. Liver tenderness, hepatomegaly, and increased LFTs are characteristic. And light microscopy of liver biopsy specimens reveals widespread central lobular hepatic necrosis. Halothane-associated hepatitis has up to an 80% mortality rate, and sadly, there's no specific therapy for this condition. The anesthetic enflurane is associated with a few adverse effects as well, including nephrotoxicity.
Oh, right in the kidney!
And convulsions.
Just look at that piñata go!
And lastly, one of the most important adverse reactions to remember for the exam is malignant hyperthermia, and in this sketch, it will be represented under that magnificent happy birthday banner in the back. Malignant hyperthermia is a syndrome that occurs due to hypersensitivity of skeletal muscles to volatile anesthetics. It does not occur with nitrous oxide, volatile anesthetics only, and that's why the rest of this scene takes place above that volatile anesthetic kiddie pool. The depolarizing muscle relaxant succinylcholine is also associated with this condition. To remind you of succinylcholine specifically, it looks like little Ryan over here can't even have a birthday party with his friends without one of the neighborhood bullies showing up and adding yet another emotional scar to his already traumatizing childhood. The word sucks is our recurring symbol for succinylcholine, and be sure to check out our anticholinesterase sketch for more info on why succinylcholine really does suck. The majority of cases of malignant hyperthermia are related to a defect in the ryanodine receptors in the sarcoplasmic reticulum. And that's why the Ryan section of the banner is looking pretty droopy and dysfunctional. Ryanodine receptors are located on the surface of the sarcoplasmic reticulum of skeletal muscles and act as calcium channels during muscle contraction. Abnormal ryanodine receptors release large amounts of calcium after exposure to anesthetic, stimulating its ATP-dependent reuptake by the SR. Excessive consumption of ATP generates heat, so remember that flame theme we've incorporated into the banner, as well as this hyperthermia-evoking party cap. Loss of ATP along with high temperature induces muscle damage, so Ryan holds our recurring sketchy symbol for rhabdomyolysis. The old chicken leg with a bite out of it. On the exam, they might clue you into the fact that it's rhabdomyolysis because lab values show the release of potassium, myoglobin, and creatinine kinase into circulation. Clinically, malignant hyperthermia presents with fever and muscle rigidity soon after surgery under general anesthesia. Tachycardia and hypertension are also characteristic. Malignant hyperthermia is life-threatening and should be treated promptly. Your go-to agent? Dantrolene, represented by the dantrolene trampoline. Dantrolene is a muscle relaxant. Specifically, it acts on ryanodine receptors and prevents further release of calcium into the cytoplasm of muscle fibers. And that's why the adult that's manning the trampoline is directly inhibiting little Ryan over here.
Whoa, whoa! No eating on the trampoline, son! Just set that rhabdo chicken down and take off that malignant hyperthermia cap. You're always embarrassing your mom and I, Ryan. Why can't you be more like your sister, Ryan? Sorry, let's just leave that buried.
Alright, to sum up this sketch, just remember partition coefficient is kind of the same thing as solubility. Less soluble anesthetics are quick to saturate the blood, leading to a fast onset of action and a fast recovery. More soluble anesthetics have higher partition coefficients and they saturate the blood more slowly. A lot more needs to dissolve, so the onset is more delayed and recovery takes longer. MAC is the concentration at which 50% of patients are likely to become unresponsive, and 1 over MAC is equal to potency, that gooey, cheesy potency. For side effects, remember hepatic necrosis with halothane and malignant hyperthermia, which involves fever and muscle rigidity soon after surgery under general anesthesia. And for the rest of the side effects, just think of clowns. They seem harmless and fun, sure, but clowns are out to get you. So hide your kids. Just like the severe cardiorespiratory depression that can be induced by inhaled anesthetics, they're just waiting for you to fall asleep so they can creep into your room and suffocate you. Sleep tight, Ryan.